Great. So now that it is 33 past, we're going to go ahead and get started. So thank you all for joining us for our Hepatitis C webinar. As you all know, May is Hepatitis Awareness Month, and so we really wanted to host a webinar that kind of focused on giving you all an overview of hepatitis C, how it relates to Black communities, and really give you some more information on how to get involved in hepatitis C advocacy, and give you some tools that you can use in your own communities if you're interested in advocating for hepatitis C. So we're definitely glad that you were able to join us, and we're excited to get this webinar started. Just a few housekeeping rules. If you're interested in asking a question during the presentation while our speaker is speaking, please feel free to do so. There are two options that you can use. You can, on the panel to your right, there's a little button that has a hand with an arrow. You can raise your hand, and then I can unmute you, and then you'll be able to ask your question. There's also the questions feature within that panel to your right. So you can type the question in the question chat, and then once I see that you have asked the question, I can ask it for you to our speaker. Also, if you're having any visual or audio difficulties, please close out of the system altogether, log in again, and make sure that you download the Citrix software, because if you don't, it will not work. Those just for housekeeping. So quickly, I'll give you an introduction to our speaker. He has a very long bio, so I'm not going to read all of it, but we're very grateful to have Rich Feffer, who is from Hepatitis Education Project, with us today. And so he is the Correctional Health Programs Manager at Hep Education Project, and Hep Education Project is a Seattle-based nonprofit. They provide hepatitis C outreach and medical case management and educate the community members and medical providers about viral hepatitis. So in his role at Hepatitis Education Project, Rich teaches viral hepatitis classes directly to offenders in 13 Washington State prison facilities, trains inmates at 2 of those facilities to talk to their peers about HIV and hepatitis C risk reduction, and advocates for better access to hepatitis C testing and treatment in corrections. And so, as we probably all know on this call, hepatitis C is something that's very common among people who are incarcerated. And so the work that Rich is doing is very useful, and we at the Black AIDS Institute are in awe of the work that you're doing, and we're hoping that it can be replicated in other cities and states across the country. So without further ado, I will turn it over to Rich.
Thank you very much. I appreciate that. And just let me know at any point if you have any difficulty hearing me. So like Rebecca mentioned, I work for a small nonprofit in Seattle called the Hepatitis Education Project. We provide kind of a little bit of everything hepatitis-related education, advocacy, community-based outreach, medical case management, and patient navigation, as well as just basic patient support. And what we're going to talk about today is I'm going to try to provide a little bit of an update on what's happening with hepatitis, particularly hepatitis C. We're going to go a little bit forwards and then back up a second. So we're going to start with kind of the big picture, basic epidemiology, and then we'll kind of reset a little bit and focus on exactly explaining and giving folks an update on exactly what hepatitis is, how hepatitis A, B, and C are transmitted for those that need that information. And then what we'll do is we'll talk a little bit about treatment updates and what's happening in the country related to access for hepatitis C treatment. We'll talk about HEPS programs and some of our resources so that people have information to follow up on programs they're interested in learning more about, or resources that they may need. So next slide, please. Great, so we're going to get started with just kind of Hep C basics. Like I said, epidemiology to start with. The CDC has estimated that between 2.7 and 3.9 million people are living with hepatitis C. The actual number is probably higher. The reason for that is because the NHANES study, which is used to calculate that number, does not include some of the highest risk populations for hepatitis C, including people who are homeless or people who are incarcerated. And so there have been a number of studies that have come out that have estimated that number is actually probably close to 5 million. And that actually makes it the most common bloodborne infection in the United States. And there are still a lot of new infections. New infections peaked in the late 80s And when we were still not screening the blood supply, hepatitis C was discovered and isolated in 1989. And so in 1992, there started much more widespread screening of the blood supply. And at that time, that was the source of most new hepatitis C infections. Now that we screen the blood supply and have since 1992, most new infections are associated among people who inject drugs. And there is an epidemic among young people who inject drugs. They're getting hepatitis C at the highest rate. Additionally, we incarcerate drug users in this country, and so we find high rates of hepatitis C in our prisons and jail systems. Largely not, and a lot of folks tend to think that this is largely due to transmission while incarcerated. In reality, it's probably closer to the fact that we incarcerate higher risk populations at higher rates. And so one of the things that we have learned as we explore epidemiology around Hep C is we don't have great surveillance resources for hepatitis C the way we do for other viruses and other diseases. And so what we find are large ranges in terms of the estimates. So you see CDC estimates between 2.7 and 3.9 million. And what we see for new infections is somewhere between 20,000 and 85,000. So we've got a long way to go to get that number kind of figured out. But we know that the primary driver of new infections is use of injection drugs. Another thing that we've learned is that about 75% of those with chronic hepatitis C are born between 1945 and 1965, that baby boomer cohort. And around a year or two ago, I can't remember the exact date, the CDC came out with a testing recommendation saying all people, regardless of any other previous risk factors, born between 1945 and 1965 should get a hepatitis C test, a one-time test. And so if you are working with baby boomers, people born in that age range, if you have parents or loved ones in that age range, please encourage them to get tested. That would really help us with our final point, which is that 50% or more of those with hepatitis C are unaware of their infection. And that's because a lot of times hepatitis C does not cause any symptoms until many years later when the liver has already been significantly damaged. So people can live with that infection for a long time, often 20, 30, and potentially even 40 years before developing significant symptoms. Even those who do have symptoms, many times the most common symptom is fatigue, and most folks don't associate fatigue with hepatitis C. They may feel they may not realize they're feeling fatigued, but it doesn't often spark people to go to the doctor and get tested for Hep C. Now, next slide, please. So this is a little bit more of kind of the natural history of Hep C, and we're going to go back into what Hep C is here in a moment. So I don't want to focus for too long on this, but one of the things that is confusing about hepatitis C is that different things happen to different people, and some people get sick and they get sick sooner. Some people never get sick even if they live with that infection for a long period of time. And so this gives a little bit of information about what some of the averages are. If there were 100 people that have hepatitis C and none of them received hepatitis C treatment. So if we had that 100, one of the interesting things about Hep C is about 20% of people fight off the infection naturally, and their immune system resolves it. So if 100 people are infected, around 20 will actually clear the infection without any medication within 6 months of being infected. The other 80% will develop chronic disease, which will be a lifelong infection if they are not treated and cured. Fortunately, now we have very effective cures for hepatitis C. Of the individuals living with chronic infection, a little bit under half will be stable for long periods of time and will not develop significant liver disease. But a little bit over half will develop significant liver disease, including cirrhosis of the liver and liver cancer. And again, untreated, it's estimated that around 1/4 of that initial group of 100 would face mortality, end-stage liver disease, or other comorbidities as related to hepatitis C. So we'll talk more about mortality here in just a second, but one of the things that's important to understand is that there's really no test to determine who's going to be stable and who's going to proceed to cirrhosis. And so anybody living with hepatitis C needs to be seeing their medical provider regularly and discussing the option of treatment. With new treatments, the Society of Liver Disease recommends that everybody can be a candidate for treatment with all the treatment advances that have happened. So with that, we're going to focus on in a little bit here. We're going to continue to talk about some of the basic epi. So next slide, please. So in 2007, hepatitis C surpassed HIV in terms of number of deaths annually, and those deaths are continuing to rise. That's in the United States naturally. Next slide, please. In Washington State, we actually surpassed that in 1997. And so one of the things that has been really interesting is that the HIV community has done a really amazing job, and to all their credit for in some of the advancements they've made in terms of getting people diagnosed and getting people connected to treatment and getting people virally suppressed. We know that there is a long way to go in that fight as well, but one of the things that we're seeing is that we're not doing such a great job in terms of hepatitis C, both at the state level where I live and also nationally. So next slide, please. And this is what we see. We see a rise in deaths, and this is an estimation of when deaths related to hepatitis C are going to peak. Now, in 2013, there were about 19,000 death certificates that listed hepatitis C as a cause. And the CDC actually explains that that is more likely a fraction of the deaths attributable to HCV. There are many comorbidities and other causes of death related to liver failure. And so a lot of times, even if someone dies from a complication related to hepatitis C is not listed as a cause of death. So we are likely facing a much larger problem. The chart that you're looking at doesn't correlate in terms of numbers, but does project the idea that we are seeing an increase in deaths and that deaths from hepatitis C are expected to peak somewhere in the late 2020s or early 2030s. And the reason for that is largely because of what I explained earlier, that many people don't progress to serious liver disease until they've been infected for 20 or 30 or 40 years. And what we see now is that around 75% of all people with hepatitis C are in that baby boomer generation, and many of those people have been living with that infection, many of them unaware, and many of those people are aging into liver disease such as cirrhosis or liver cancer. And we don't have resources available to do a great job getting people diagnosed and linked to care just yet. So we're working towards that. Next slide, please. This is what's called the HIV cascade of care. And this is for HIV. And what we see is that we've got a long way to go, right? There are around 82% of people are diagnosed, meaning that around 18% are undiagnosed, 66% linked to care, 37% retained in care, around 1/3 are prescribed antiretroviral therapy. And by the time you get to the bottom of the cascade, after you get past all those loopholes, we've only got about 1/4 of people who are virally suppressed. And so while we've done a great job with HIV, we definitely still have a long way to go. So if we're looking at that and we know that we have a long way to go with HIV, let's take a look at hepatitis C. Next slide, please. And so we've got an even longer way to go. Our actual diagnosis rate is much more around 50%, so diagnosed and aware. Can you click, Rebecca? There's 2 boxes that should pop up. So there's one, so that's one number I want us to focus on, and the other, by the time you get to the bottom of the treatment cascade, is that 9%. So we've only got about 9% of about 3.5 to 5 million people who are living with this infection who have achieved what's called SVR, or sustained virologic response, which is tantamount to a virologic cure in the case of hepatitis C. So we have a long way to go in terms, especially in terms of testing and linkage to care and getting people access to the medicines that they are prescribed. Next slide, please. And this is a little bit of a comparison in terms of resources that are allocated. And what the HIV community has done very, very well is advocate for resources, and they've done a credible job. And we are very much trying to follow the example of this community in the community that we're working in with hepatitis C. And what we find is that while the number of infections for hepatitis C, so if you look on the left-hand side, that reflects the total number of people who are infected, and the yellow line is HIV, or orange line, depending on your computer screen. The purple is hepatitis B, and the blue is hepatitis C. So we see that there are many more people living with hepatitis C. Simultaneously, if you look on the right-hand side, what we see is the way that care, prevention, and research dollars are funded. And what we find is that in the billions of dollars, that HIV funding is far greater than funding for hepatitis B or hepatitis C to a large degree. And that is not to take away from the work that has been done on HIV. We want to emulate that work, but we know that we need more to be able to get to the point that these other efforts are. And we know like I said, we've got a long way to go. So that's a little bit of the big picture in terms of what's happening in terms of epidemiology and dollars for research and funding. And so we're going to kind of back it up a little bit now and talk about some more of the basics. And I'll take questions at the end related to this as well. So next slide, please. I also wanted to point out the fact that hepatitis C does disproportionately affect African Americans. The Hep C prevalence among African Americans is a little over twice as high as that of non-Hispanic whites. The overall prevalence rate in the United States is between 1% and 2%, so it is overrepresented compared to the overall general population. And so African Americans are 11% of the population, but they represented only 25%, or actually 25% of the participants in the NHANES study living with hepatitis C. One of the things that is really important is to understand that in the past, therapies and treatments for hepatitis C included a drug called interferon, and those therapies were not terribly efficacious in comparison to what we have now. And old interferon-based therapies actually had a significant difference between their effectiveness in whites and their effectiveness in racial minorities. The newest therapies that have been released and the newest drugs that have been released have cure rates across the board as high as 90 to 100%, and there are no difference in treatment response rates for African Americans compared to other races. So we really are at the place that almost everybody can be cured regardless of race and ethnicity and socioeconomic status, but there are many barriers in the way between people and their medicines. Next slide, please. So we're going to talk a little bit about hepatitis and how it works and get some of those basic points out there, and then we're going to refocus on some practical strategies that people can use and resources that people can have. So I don't want to reiterate this too much for everyone, but I do want to make sure everybody has a good understanding. Hepatitis is something that affects your liver. And if you could click one more time, please. What we know about the liver is that it is your second largest organ. It is your largest internal organ. Your largest organ by weight is actually your skin, so that's your external organ. It has over 500 functions. I don't know all of them, unfortunately, but I do know some of the most important ones. And the most important function is that it is a filter for your blood. It filters toxins that enter your blood via food, via air, via creams that you put on your skin, things that you smoke, things that you inject. Just about anything that you put into your body, if it enters your bloodstream, it needs to be filtered and processed through the liver. It also helps your blood clot so that you stop bleeding when you're bleeding. It also helps you digest your food, and it helps regulate vitamins and nutrients. Those are some of the most important functions of the liver, and when I teach this in our correctional systems, I really talk about the function as a filter, and that's probably the most important thing to focus on. Another thing that's important to understand related to hepatitis C and the liver is that the liver is what they call an uncomplaining organ. It is often unable to feel pain because it lacks nerve endings, the same way that somebody's fingernails or hair lack nerve endings. And so what we find is two things. One, someone can have hepatitis and have inflammation of the liver due to hepatitis and not have any sensation from that. And so they might have hepatitis, they may know they have hepatitis, but they may feel perfectly fine. And so many people aren't motivated to go to the doctor or don't understand the potential that hepatitis C can be serious because they don't feel any pain. The second thing that can happen is because people might not feel it, they may not know they have it. It is probably one reason for our low diagnosis rate. So that fact that your liver is an uncomplaining organ has an impact. Your liver is unique in its ability to regenerate and heal to a large degree. So if somebody has liver damage from hepatitis B or hepatitis C and gets cured or suppressed, suppressed in the case of hepatitis B, cured in the case of hepatitis C, especially in the case of a hepatitis C cure, some of the liver damage, in fact much of the liver damage that's been done over time, can actually be regenerated and healed. And so we see cases where people have a certain stage of liver scarring, they get treated and cured, that infection is no longer hurting their liver, and they actually progress and their liver heals. That is actually something unique to the liver. There are other organs that regenerate, but your liver is one of the best. Next slide, please. So when we refer to hepatitis, we're actually referring to a two-part word, and it's a general term. It actually just means liver inflammation. So click 2 more times for me. Hepa means liver, and itis means inflammation. The way that I always talk to clients in terms of helping them remember is itis is any kind of inflammation, and I'll kind of summarize some of the itises that are out there: gingivitis, inflammation of the gums; tonsillitis, inflammation of the tonsils, etc. So it always helps folks to know that Hepa means liver, itis means inflammation. Now, long-term liver inflammation can cause scarring, and that scarring is when it becomes severe enough is called cirrhosis. Next slide, please. Cirrhosis is a condition in which the liver is so scarred that it starts being able to have difficulty doing its basic functions. And what we see here is a healthy liver compared to a cirrhotic liver. The healthy liver is smooth on the outside, it's red in color. If you were able to give it a little squeeze, it would feel like a sponge. Our liver with cirrhosis is covered in hard, rubbery scar tissue. It's often shrunken in size. It gets darker in color. Now, cirrhosis can be severe, or it can be, it's always serious, but there can be compensated cirrhosis where the liver is still functioning fairly well, or at least able to perform its basic functions, and then there's decompensated cirrhosis where the liver is starting to shut down. Hepatitis C is the leading cause of liver failure and liver transplant in the United States. And people with hepatitis C often develop cirrhosis before developing liver cancer. In the case of hepatitis B, people can actually develop liver cancer even before they develop cirrhosis of the liver. This process between a healthy liver and a cirrhotic liver is not an overnight process. For most people, this is a decades-long, slow-progressing condition, and so a lot of people live for 20 or 30 or 40 years before developing liver damage to this degree. Additionally, there are many people who will live with hepatitis C infection and never develop cirrhosis. So monitoring is very important, and treatment can prevent that progression even so that we don't have to monitor as much. In the past, when treatment was less efficacious and had massive side effects, there was a group of the population that was probably a better candidate to be monitored over time. Now we're getting to the point where virtually everybody is a candidate for treatment. Next slide, please. This is just a demonstration of why cirrhosis causes problems. What we see on the left is a healthy liver. This is a slide that I like to use when I'm teaching classes, both in a correctional and non-correctional setting. What we see on the left is your healthy liver, right? So your healthy liver has blood that is able to flow through the way that coffee flows through, or the way that water flows through a coffee filter, and you see toxins in the bloodstream being cleaned and coming out clean on the other side. Cirrhosis is a condition where you have lots of scar tissue, and scar tissue is not very soft and spongy and porous. Scar tissue is hard and rubbery, and what we find is that the blood flow through the liver is constricted or often blocked by scar tissue and the shrinking of the liver. And so people with cirrhosis often develop high blood pressure in their portal vein, which is the vein that pumps blood through the liver. And so we see things like varices, where the veins stretch and they can burst and cause internal bleeding. And we see a buildup of toxins in the bloodstream because the blood is not able to pass through the liver in order to be cleaned. And that is what causes significant actual clinical symptoms and clinical problems when it comes to cirrhosis. Next slide. And the main causes of hepatitis, and because hepatitis is a general term that encompasses all kinds of liver inflammation, so we can have autoimmune hepatitis, there are other kinds of hepatitis. You can have alcohol-induced hepatitis. So a lot of folks know that alcohol is bad for your liver. Well, when you go home and you drink a six-pack of beer, or if you drink something with your friends, then people can develop mild to severe liver inflammation. Now, if somebody doesn't drink for a couple of days or takes some time off and is moderate in their alcohol consumption, that liver inflammation doesn't lead to severe damage down the road. But in the case of someone who drinks regularly, constantly, all the time, there's inflammation that doesn't really get a chance to heal. And that's a little bit of how the chronic hepatitis B or chronic hepatitis C viruses work. These viruses they are transmitted through blood. They live in the bloodstream, and they use liver cells to make copies of themselves. And so they cause direct inflammation to the liver. Now, if they were short-term infections, the liver can regenerate and heal. But in the case of hepatitis B and hepatitis C, these viruses are often long-term chronic infections that cause liver inflammation that doesn't go away, and that is what can lead to scarring of the liver, which can help develop cirrhosis. Next slide. So hepatitis A, B, and C are all different. They all cause liver inflammation, which is why they are called hepatitis. They are named in order of discovery, not in order of how severe they are. And especially when I'm teaching to populations that have a less health education in their background, I always like to point out the fact that they don't turn into each other. So A does not lead to B, B does not lead to C. They really are different things, although they all cause liver inflammation, and they have some similarities in terms of clinical symptoms that can be presented. Next slide, please. So this will be just a quick transmission comparison between hepatitis A, B, and C. I'm not going to go through hepatitis A and B in detail in terms of epidemiology or other things, but we're going to focus on hep C. But hepatitis B is also a significant public health issue nationally and internationally, and so if you'd like to learn more about that, you are welcome to email me. Hepatitis A is a fecal-oral transmission route that is spread, therefore, usually by ingesting contaminated food or water. So you might have a food service worker, if they're infected with hepatitis A, they use the restroom, they don't wash their hands very well, and they can serve food to others, and those people can become infected. Unsafe sex, if people are having any kind of anal or oral sex, can also be a risk factor. Hepatitis A is a short-term infection. It's an acute infection, much like the flu. However, it can be dangerous if somebody has chronic hepatitis B or chronic hepatitis C. So one of the best things to do is be vaccinated against hepatitis A and hepatitis B if somebody has hepatitis C. So it's very important. Vaccination is the best way to prevent hepatitis A and hepatitis B. We have very safe, very effective, very affordable vaccines, and so we really focus on pushing these hepatitis A and B vaccines where possible. Hepatitis B is spread very differently. It's spread very similar to HIV. HIV is spread through semen, vaginal fluid, blood, and breast milk. Hepatitis B is spread through semen, vaginal fluid, and blood. However, hepatitis B is quite a bit more infectious than HIV, around 30 times more infectious. But we do classify it mostly as a sexually transmitted disease, and many people are actually born with hepatitis B if their mother is born with if their mother is living with chronic hepatitis B. That's particularly endemic in Asian and Pacific Islander communities. They are far overrepresented among people living with hepatitis B. Because of their many people come from high endemic countries with little vaccine access. But because it's also spread in blood, it's spread through drug, tattoo, and piercing equipment that's been used and not cleaned and that has been shared. People with hepatitis B, if you acquire and are infected with hepatitis B as an adult, 90% of people fight off that infection naturally. But the other 10% can develop long-term chronic hepatitis B. If a child is born with hepatitis B, on the other hand, 90% of them will develop chronic infection, although if they're vaccinated early, they actually have the ability to fight off that infection 90 to 95% of the time. So awareness about this vaccine is very important. So for hepatitis B, we focus on getting vaccinated and making sure we encourage safe sex, safer drug use, safer tattooing. Both of Hep A and B are preventable by vaccine, but hepatitis C does not have a vaccine, although hepatitis C, if someone is chronically infected, can be cured. Next slide, please. All right, so hepatitis C is spread through blood-to-blood contact, and it is not spread through semen or vaginal fluid the same way that hepatitis B is. So when we talk about blood-to-blood contact, we need to examine the different ways that blood-to-blood contact can happen. Next slide, please. Blood transfusions before 1992 drove most new infections before we started screening the blood supply in 1992. That's part of the reason for the high rates among baby boomers. And most new infections today are driven by injection drug use. So next slide, please. This is the #1 way that Hep C is spread today. One of the things that's different than HIV is that HIV doesn't live outside the body for very long. Live virus that can be transmitted doesn't live outside the body very long. So when we talk about not sharing syringes, that's a great prevention message. One of the things that's important to counsel people who are using drugs on is recognizing that with hepatitis B and hepatitis C, these viruses can survive on surfaces and in water solutions for a long period of time, as little as 5 days, and there was a study that showed live hepatitis C virus inside the barrel of a syringe as long as 63 days out. So sharing any injection drug equipment, not just the needle, can pass hepatitis C and hepatitis C. That includes needles, syringes, cottons, cookers, rinse water, tourniquets, gauze, the actual drugs themselves. Anything that has blood from another person, if somebody injects it using that equipment, even if they're using their own brand new syringe and they share a cooker, for example, or a cotton, for example, that can spread hepatitis C. Cleaning these supplies with cold water does reduce risk, but it does not eliminate risk. We always counsel clients that the best choice, the safest choice, is not to use drugs, but we also recognize that many people choose to use drugs, and we are advocates of harm reduction, and we really focus on letting people know that making sure to use all new works when they inject and never sharing those works is important. These are this picture is supplies that we are available at one of our syringe exchanges in Seattle, and we see cottons, cookers, water, tourniquets, Band-Aids, gauze, all of the equipment that would be needed to have a safer injection surface and a safer injection itself. Next slide, please. Tattoos are also high risk for hepatitis C, again because that virus can survive on the point of a needle. It can also survive in ink. The wetter the environment, the longer the virus can potentially survive. Tattoos done in a prison setting or a jail setting or other settings that are not in a licensed tattoo shop where people have access to autoclaves and access to disposable ink and needles and access to sterile equipment are the most risky. So this is a major problem in prison settings where tattoos are often not talked about but are often happening a lot. And people in prisons don't have access to clean equipment, and tattoos themselves are sanctioned, so people keep them on the down low. So this is not something where people are using clean equipment. It's a significant problem, and we focus a lot on injection drug use, and I think that tattoos are an important aspect that we often miss. So it's important to counsel people to, if they're going to get tattoos, to get them in licensed shops. Licensed shops are expensive, and not all clients choose to go that route. And so it's important if they get one from a friend or if they get one in a correctional setting that they use a new needle, ink, barrel, and gloves every single time. Next slide, please. So when we talk about risks for transmitting hepatitis C, we're talking about classifying degree of risk of blood-to-blood contact and viral transmission. So the highest risks for blood-to-blood contact today include injection drug use, tattoos, and before 1992 it was blood transfusions. But there are other potential risks of blood-to-blood contact that we can think of too. They're lower risk, but they're certainly potential. That includes snorting drugs, if people share straws or dollars to snort drugs, sharing personal hygiene equipment like toothbrush, razors, or nail clippers, getting into bloody fights or getting into rough fights. Sexual transmission for hepatitis C is relatively low because it is not spread through semen or vaginal fluid. However, people do acquire hepatitis C sexually. Hepatitis C, there must be blood-to-blood contact, so there has to be blood from the person with hep C and an open cut or open sore on the other person. But some potential scenarios where people can experience higher risk for sexual transmission, and that what's been shown in the research is that there's higher risk among men who have sex with men. There's also higher risk if someone is co-infected with HIV. And there is higher risk among people who have sex for long periods of time, which is actually something that is fairly common among people who use meth. Occupational exposure, firefighters, healthcare workers, paramedics. Good thing that folks wear gloves these days. In the 60s and 70s, they did not. Needle sticks are relatively low risk, but it's certainly something that you would want to make sure you get tested if you have a needle stick or other occupational exposure. These viruses, Hep A, B, or C, are not spread through casual contact, so sharing food or drinks, just living in a household has not been shown to be a risk factor for acquiring hepatitis C. Next slide, please. So we are getting to a place where treatment has advanced really rapidly. One of the physicians who we work with actually called it one of the major advancements and major achievements of science in the last couple of decades. It really is amazing in the short period of time where we've come. So if you look at when we really discovered hepatitis C in 1992, the first therapies were just using a drug called interferon. Interferon is an injectable drug. It is a naturally occurring chemical that helps your immune system fight infection. And when we inject high doses of interferon, it helps the immune system attack an infection. However, it also causes significant side effects, including nausea, vomiting, diarrhea, hair loss, significant mental health side effects, depression and suicidal ideation, so not a terribly pleasant drug. And in the early 90s, we were using interferon alone to treat hepatitis C, and as you can see, the response rates for 6 months and 12 months of therapy were between 6 and 16%. So you're talking about 1 year of being on an injectable drug that made you feel terrible, and about a 16% chance of being cured. We later added a drug called ribavirin to that regimen that brought the cure rates up closer to 40%. We then started using a better version of interferon that instead of being injected 3 times a week is now injected once a week, and that's PEG interferon and ribavirin. And so through the 2010 calendar year, the highest rates that we were really seeing of efficacy were around 55% for 12 months of pegylated interferon and ribavirin. So again, 12 months of not feeling so hot for about a 55% chance at being cured. In 2011, we had the first new drugs released that were protease inhibitors, and these drugs, when added to the PEG interferon ribavirin regimen, brought cure rates for genotype 1 up to about 70%. The big breakthrough really came in 2013, and this is what all the hype and media, if you've been following any of it, has been about over the last couple of years. In 2013, the first direct-acting antivirals were released. People were able to be treated and are now able to be treated in as little as 3 months. The first regimens were approved for use with PEG interferon and ribavirin, but the cure rates went up to 90%. Now in 2015, since 2013, there have been 4 new medications that have been released to treat hepatitis C from 2 manufacturers. So when we now have multiple direct-acting antivirals, depending on a person's genotype or strain of hepatitis C that they have, they are able to be treated with whatever the appropriate combination of medicines is, and we have new medications coming. The newest medications are around 95% efficacious in almost all circumstances, so we've really come a long way. Next slide, please. So the treatment options for people with hepatitis C are genotype dependent. It does depend on other medical factors as well. But many of the old contraindications, such as whether or not somebody had failed treatment before, whether or not somebody had other comorbidities, patient's age, degree of liver scarring, are no longer factors. People can largely be cured at 90+% rates across the board. But which drugs they take depend on their genotype. The most common genotype of hepatitis C is genotype 1. That is represents around 75% of all people living with hepatitis C. And there are 3 choices. There is Harvoni, which is the first 1-pill, once-a-day regimen manufactured by Gilead Sciences. There is also a 3-drug combination from AbbVie called Vicira Pack that you use with or without ribavirin. And there is also the combination of Olysio and sofosbuvir. All of these regimens are all of these regimens are around 12 weeks in length. Harvoni, for certain patients can actually be prescribed and effective in only 8 weeks. If you have genotype 2 or genotype 3, the FDA-approved treatments are Sovaldi and ribavirin for between 12 weeks and 24 weeks. So we're talking all oral medications, no injections for 2 to 3, potentially 6 months with genotype 3, but no longer 1 year of toxic therapy. There are 3 other genotypes of hepatitis C, and there are guidelines for people to follow regarding those genotypes. We don't see a lot of those genotypes in the United States. However, one of our medical case management clients recently got cured, and she had genotype 4, and she took interferon, ribavirin, and Sovaldi for 12 weeks. Next slide, please. So to summarize, the treatment advances for hepatitis C is that A, hepatitis C is curable. It is once somebody attains SVR, sustained virologic response, for a period of 6 months, they are effectively cured. They can be reinfected, but in the case that, but in most cases, people are cured for life. 90 to 95%, and in many cases 97, 98% of people can be cured. The treatment options are improved in the sense that they are shorter in duration, they are much more effective, and they have very few side effects. An added benefit is that they are much easier to manage. There are very few food or other kinds of requirements, but it's always best to talk to a doctor. But it doesn't have a lot of the other requirements that some of the old protease inhibitors had. Some things we know about hep C treatment is that curing hepatitis C reduces all-cause mortality. So somebody who is cured of hepatitis C actually increases their chance to live longer and not die from another cause, which is really fascinating. And the other thing that we're starting to learn is similarly how we talk about people living with HIV being on ARTs for prevention purposes, we are seeing a push for treatment as prevention with hepatitis C, especially treating hepatitis C among the most at-risk populations and among those who are most likely to potentially spread that virus. So treating active drug users and women of childbearing age could result in significant transmission reduction. And hepatitis C is a communicable disease, so by ensuring that we cure the populations that are at most at risk now means that we can dramatically decrease new infections. And NVHR stands for National Viral Hepatitis Roundtable, one of the national groups working on hepatitis C. And they've got a series of great webinars. If you'd like their information, you can just email me or Google National Viral Hepatitis Roundtable. Next slide, please. So the problem is, why isn't everyone getting treated? Well, the primary barrier at this time that we're all working on is the high cost of the medications. And what's happening among insurance providers and in places like prisons is that many payers are being forced to prioritize access to those with more progressed liver disease. So in the case of many insurance companies, or for example in the case of many state Medicaids, they are covering medicines for people with stage 3 or stage 4 liver scarring, but they are denying folks with stage 0, stage 1, or stage 2 liver scarring. Even though the AASLD guidelines state that everyone is a candidate for treatment, they also talk about prioritizing based on resources. So many patients are finding barriers to care. There are mechanisms in place, though, to get people who are denied, access to those medications, it requires getting denied by an insurance company, filing an appeal, being denied one more time, and at that time people are eligible for patient assistance programs. And our case managers really help people get through that process. We also have a really low diagnosis rate, as I mentioned. We need more testing. Hep C testing is a two-part process. People need to have follow-up testing, so many people are lost to follow-up. So make sure if you're implementing a new testing program or if you're working on testing policy that that is considered. There's significant need for providers to be trained on hepatitis C. It's becoming much more easier to manage from a provider perspective, and the ability for mid-levels and primary cares to treat hepatitis C is increasing. Our healthcare systems are difficult to navigate for patients and providers, and there's a lack of public and private resources for testing, treatment, and patient navigation. So again, as I stated at the beginning of the presentation, we really do have a long way to go. Next slide, please. I talked a little bit about how to pay for treatment. I want to make sure I leave time at the end. Depending on insurance coverage, it is the coverage of treatment is often prioritized based on degree of liver disease. But as I stated, both of the major manufacturers do have patient assistance programs that actually help and are relatively easy to access if you fill out the right paperwork, but it can be an arduous process to get there, going through the insurance denials and appeals process, especially for many clients who are marginalized or underinsured. So patient navigation and case management is key for these clients. If people do not have insurance, there are clinical trials available, there are charity care programs, and like I said, case management is definitely helpful, and if people are in Medicaid expansion states, there's certainly the opportunity to sign people up for insurance if they are uninsured. Next slide. So if you're counseling clients who can't get treated right now, the most important thing to talk to people about is reducing their alcohol intake and eliminating their alcohol intake if possible. Alcohol and hepatitis C do not go well together. People living with hepatitis C, if they drink alcohol, it will really cause disease to progress more quickly. Seeing a doctor regularly to be screened for liver disease and to talk about treatment options, following a healthy diet and getting regular exercise, getting vaccinated for hepatitis A and hepatitis B, and avoiding co-infection with HIV or hepatitis B are all great tips that you can offer clients that you work with if somebody is living with hepatitis C and is not currently being treated or is not able to get access to treatment. If someone has been cured, it's important to counsel them on re-exposure. Hepatitis C you can be reinfected with hepatitis C, and I don't think that anybody wants to go through treatment and be reinfected, so it's important to talk about prevention even amongst people who have been cured. Next slide. So our agency provides direct services, patient support, education, and advocacy. We were founded in 1993. We are one of the oldest and one of the only nonprofit community-based organizations that focus solely on hepatitis. Next slide. A couple of our major programs, in addition to our community outreach, our medical case management program is really growing. We provide free medical case management services. The case managers, we have 2 full-time medical case managers. They help our clients navigate the healthcare system, find a primary care or a specialist, enroll in health insurance, access hepatitis C treatment, including insurance appeals, patient assistance programs, charity care, and they will really advocate in a very supportive, compassionate way on behalf of that patient. Many of the clients that we work with in our community-based settings need help to navigate this process, and they will do whatever it takes and whatever they can to get those people access to hepatitis C treatment. That is a new program in the last couple of years, but it has really blown up, and we are really working with a lot of people. Next slide, please. One of our oldest programs is our prison and jail programs. We've been providing correctional-based education for about 11 years now, and we do 2 primary education programs directly to people who are incarcerated in Washington state prisons. One we do is a hepatitis C 101 class. We do that in 13 Washington state prisons and King County Correctional Facility. We deliver over 100 classes between those systems every year, and we reach over 1,000 inmates with a basic Hep C 101, a little bit longer of a version of what I did in the middle of this presentation today. Another exciting thing that we do is our Project Shield, which is a peer education training that we run in 2 state prisons. And what that does is it teaches inmates at those institutions 2 things: communication skills and HIV, hepatitis C risk reduction strategies. And the goal is to create a group of trained peer educators who are talking to their social networks about risk reduction. I'm happy to share information about either of those 2 education programs with anybody who wants to email me or get in touch with me. If you'd like to learn a little bit more about that, you can also check out our National Hepatitis Corrections Network website. We have a lot of the resources available there, and I can be contacted through that website. The Corrections Network is also a professional development network where we provide networking opportunities for people working in corrections around hepatitis C. So if that applies to you, I would love if you check out our website, and if you want to get involved and have opportunities for webinars, meetings, and other professional development things around Hep C testing and treatment in corrections, please do get in touch with me. Next slide. As an agency, we also provide testing and vaccinations. We have a youth outreach and education program. We provide a monthly hepatitis C meetup, which used to be our support group, but we have kind of rebranded it as more of a social meetup. It's been great. And we also, our executive director, Michael Ninberg, is often running around at the state, national, and even the international level advocating for resources. So we do a lot with a little, and we really consider ourselves to be a leader in this space. All right, next slide. So helpful resources, HCV Advocate, Hepatitis B Advocate are 2 of the best. Please do check out the Corrections Network website as well. And so with all that, I'm pretty much finished, and I hope this was helpful for everybody, and I can take some questions.
Awesome. Thank you, Rich, for your presentation. I feel like every time I hear a presentation on Hep C, I learn a little bit more and think about how we can use how we can share kind of resources between the Hep C community and the HIV community, right? So thinking about how we can kind of cross-message and things like that. So
absolutely.
So definitely appreciate your presentation. We'll be sending out all of these links and as well as the slides to everyone who is attending the webinar. Right now is the time for questions. So again, if you have any questions for Rich, you can raise your hand using that icon, or you can type your question in the question chat. And as we're waiting for those to come in, I had a couple of questions. So can you speak to a little bit about why you think that Black people are disproportionately affected by hepatitis C?
Sure. I haven't done that research myself. I think there are many areas in which African Americans are disproportionately affected by different health outcomes, and I think it is a part of that larger picture in terms of disproportionately affected by low socioeconomic status, by incarceration, and those kinds of things. So I think it's part of that picture. In terms of because there are no specific risk factors that would put someone who's African American, at greater risk. The risk factors are the same across the board, but we do know that African Americans are disproportionately incarcerated and disproportionately negatively affected by overall health outcomes as well. So I don't have a specific reason. It's kind of part of that larger picture, I believe.
Cool. Thank you. So we have, I think, 2 questions, or time for 2 questions, I should say. So we have one coming in now. So this person asks, what would you suggest to people who are in more conservative areas if they were interested in doing some of the types of Hep C advocacy that you're doing? Because I know, as you know, Washington is pretty progressive in many avenues and many ventures that the state puts on, particularly regarding to public health. They have a very intensive PrEP program that is rolled out in Washington. So if somebody is in, Alabama or Mississippi, what are some things that you think that they could do in order to kind of do some of the Hep C advocacy that you're doing?
Yeah, so that's a great question, because you're right. There are certain states that are more progressive that are doing more, and even in those states, we've got a long way to go. But in my work with the prisons, we see this a lot, that there are other states that are less progressive and have less access to resources and have a little bit more political challenges in terms of getting things through. And so what I would suggest is we have a really long way to go with hepatitis C, and we want to get people treated, but one of the things that's important is getting people tested as well. And so I think focusing on some of the lower hanging fruit to start with and continuing to build relationships, especially being able to, if you can evaluate and show some of the positive results of your efforts in the future. So if you start a testing program, making sure you document well what the results of that are. So looking at testing in addition to treatment is a key. Another thing is advocating for the fact that letting folks know that hepatitis C is not just a drug user's prisoner's disease. This is a disease that affects 5 million people, 5 times as many people that are as living with HIV, and it is something that affects people's mothers, fathers, brothers, sisters. And I think what was really actually helpful in destigmatizing hepatitis C a little bit is to let folks know about that baby boomer recommendation. A lot of our legislators are a little bit older. A lot of them are from that generation or have family members in that generation. And I think it makes it a little bit more tangible to think that they might be somebody who needs a hepatitis C test. And I think it just makes it more real for people and a little bit less, takes some of the focus away from some of the more stigmatized populations. Another thing to do is leverage some of the HIV resources and use models that have been created by the fabulous work that HIV advocates have done to propose hepatitis C interventions as well. We've got some great models. They're not always the same diseases, but there are many things that we can learn from each other. So using some of the leverage that you have around programs that are existing for HIV and Hep C. One of the better presentations that is on our website on the Corrections Network was done by D'Elda Robertson of Louisiana, and she talked about how to work with corrections with no budget. And so she was facing a political situation in Louisiana where there wasn't much interest in providing Hep C education, and she was able to work with folks there. So there are ways to do that. And so I think starting small, making it, humanizing it and destigmatizing and using the tools at hand. And then also, I think the last thing I would mention is, when we're talking about advocacy work, what really makes an impact for legislators is money, right? So everybody focuses on the cost of the medications. What we're not focusing on are the long-term benefits of getting people treated now, and also the fact that healthcare spending for hepatitis C is already exorbitant. And if you'd like more information about healthcare spending on Hep C, I could probably direct you to resources that can help you describe that argument.
Great, thank you. I think those are some really great suggestions that people can kind of run with, and I think that we'll, as we start to incorporate more hepatitis C programming into the work that we do here at the Black AIDS Institute, we'll definitely take your advice and ways to kind of get that moving, even despite the barriers. So thank you for that.
Absolutely.
And before we close, this is Rich's information. And I'll definitely send this out in the email as well. But before we close, I just want to give you all a few announcements. First, I ask that you complete the survey for today's webinar. It should launch as soon as the webinar ends automatically. So take that. It'll only take 1 or 2 minutes for you to complete that. And then if you're interested in hosting a brown bag lunch event in your community based on what you heard today from Rich, please submit your flyer forms to me by June 1st so that you can get your professionally designed flyer to promote your event. Next, we have, I wanted to let you all know that our AHU applications are still open. AHU is our year-long Science and Treatment Fellowship that takes place here in Los Angeles, and it starts this August. We extended application deadline until June 1st. So if you're interested in AHU, please shoot me an email so I can get you the application information so that you can get on board with that. And then finally, remember that we are giving away a free Kindle Fire to the top performing Brown Bag Lunch leaders. So if you're interested in getting the Kindle Fire, you must submit your report back forms so that we have all that information from your events on file. Just before we close, we got a comment, not a question, from Jennifer, and she says, thank you for the thoroughness of your presentation and the information that you provided. It was much needed. So that's to you, Rich. Thank you again. Like I said before, I always learn a lot, and we're really happy to have worked with you, and we look forward to work with you in the future. And again, to everybody on the call, we will be sending out all of this information so that you'll have it on file, and that if you're interested in doing hepatitis C advocacy or hepatitis advocacy in general, you'll have those resources that Rich was talking about earlier. So thank you again, Rich, and I hope you all have a great week.
My pleasure. Thank you.
Bye-bye.